Well, good morning to you. Welcome back to our podcast.
I'm glad you guys are back for another round. That means you guys must have liked the first one,
Hmm.
if you even knew about it.
Um, we want to at this time acknowledge and appreciate our sponsors.
Yeah, so I'm going to start off our sponsors for today's podcast
Diet
are
Mountain Dew.
Diet
Yeah.
Mountain Dew. Hi.
Just kidding.
Yeah, that has a lot of caffeine in it,
We'll
right?
talk more
So
about that. We'll
I
definitely
don't know
talk
that
more
that's
about
our
that.
sponsor, but our sponsors are Prenatal Vitamin. They're great. Every woman should take the prenatal vitamin. They come in pill and also gummy form. So they're wonderful, help prevent neural tube defects. So all pregos should be taking their prenatal vitamins, getting that folic acid in.
I think I might have, I don't know if I shared with my class or not, when my daughter shared with me that she and her husband were attempting to get pregnant. I made her start prenatal vitamins. So really, I mean, optimal nutrition, even at the time of conception, is probably best. So a lot of people who are attempting to get pregnant will start those prenatal vitamins. That's how important it is for optimal pregnancy outcome, including those open neural tube defects and the folic acid. So
Yeah, we definitely want to do that.
yeah.
So other things pregnant people could take too, iron. There's no such thing as too much iron, right?
Well,
There is.
tell
But
you
I mean, when
what,
you're pregnant, you need it because you're gonna have that drop in your H&H sometimes.
iron definitely helps. I got to tell you, we talked a little, I think in my class today, I think we talked a little bit about anemia and the use of iron. Iron, it's hard to get, compliance is tough with iron because there are some side effects that people might find unpleasant. Constipation,
Yeah,
number one. Number two, their poop looks all dark, like black, and you're
yeah.
wondering what's going on. For you nurses, you might think that's like GI bleeding and that sort of thing. But if there's iron and that's what it's associated with, most likely.
Yeah.
The other thing, so I mean, if constipation is a concern, increase fiber,
Up your
increase
for
fluids.
That's
Yeah,
what I tell everyone. Up your fiber,
up the
up
fiber.
in your black
Walk around, do all those things, and be ready for that black poop when it comes. The other thing to keep in mind is taking it with vitamin C or like taking it with a shot of OJ, orange juice is perfectly reasonable just to enhance the absorption of that iron that they're taking.
Bring a shot of OJ, yeah, because they shouldn't be drinking, right? Alcohol. So
Well, I'm not saying have a
okay.
mimosa,
Yeah.
which is of course orange juice and champagne.
How do you know?
I was a bartender.
Very nice, very nice.
That's the only reason.
Yeah, good old days, huh?
The good old days.
Okay.
But let's talk for a minute about caffeine. What do you say?
Caffeine, is it bad or good? I mean, I don't know. There's mixed reviews, right? So there's no really definite terrible thing, but it can lead to anemia if you have too much. So
All right, it's good to
no more
know.
than 200 milligrams.
That's the key. I don't know what a cup of coffee is.
I think it's
Um,
just about under 200.
so what the thing is, if somebody's,
12 ounces, I think, is what you can have.
you can still have like your morning cup of coffee. You just can't like pound back energy drinks.
Yeah.
There's things like my diet Mountain Dew, hideously terrible for my body. I'm not of childbearing age, clearly. But I mean, there's other things. There's other chemicals, other things. Outside of just the caffeine, there's aspartame and all those other things that you're not supposed to have. So I agree, I shouldn't, if I was pregnant, I should have kept away from that, but
Yeah. So there's a few things you got to stay away from, right? Drugs, alcohol, live vaccines.
oh, there we go. I
Put
was just
that in
gonna
the
say,
mix.
let's talk
Why
about
not?
for a minute the things we should avoid. Hot tubs, saunas, because you don't want
Yeah.
your core temp to increase. But and live vaccines. So you could be trying to be your best self in terms of care for yourself, right? You found out that you were maybe not immune to rubella, we'll say, because we check for that. And or varicella, chicken pox. And you thought, well, I want to protect myself, I want to be the healthiest that I can be. Let me go get this vaccine. What's really important to know, live vaccines and pregnancy, they don't mix.
Yeah,
We
they
don't
don't
want
mix.
that.
That's not the cocktail you want.
Yeah, in fact, most times, you will get asked, no matter how old, so they ask me, is there any chance you could be pregnant? No, no, there's not. Um, for a variety of reasons. Um, so they very well might ask a patient who appears to be of childbearing age. And naturally, we don't give those vaccines in the OB world. Although most of them, I don't know about at the place you work, at my place of employment, we will offer those vaccines in the postpartum period.
Yeah.
As long as they know that they really shouldn't be getting pregnant within 3 months.
Yeah,
of
that
the
could lead to
vaccine.
birth defects.
It absolutely can, so we don't want that.
Yeah, so no live vaccine.
The other things we should avoid, and this I'm glad I
Ugh.
didn't know about.
Talk about foods.
That's what I'm talking about. Deli meats. Why?
Listeria. It's a real thing.
Who knew?
Yeah, so no deli meats, no turkey clubs, Italian subs, none of that. You know, it's like the number one requested meal, right?
It is.
Deli
It
meats
is.
and also like no raw fish. So sushi out the window. Subway out the window.
Darn
Like you
it.
can't have any of that. Can't have soft cheeses either. You know that? No brie.
My
no
gosh, there goes my entire
gorgonzola,
diet.
all that.
Well,
Yeah.
I don't have to worry about it because
Yeah.
I'm not
It's
pregnant.
like the first thing I wanted. I told people they could not visit me unless they bought me a turkey and provolone sandwich from Jersey Mike's. That was the only way you could see me and my babies. It was the best first meal.
I don't remember 32 years ago being told that I couldn't have deli meat. I just don't think it was as prevalent either. Like all these sub shops weren't
No.
around. Subway was,
Yeah.
I'm pretty
I think
sure. but-
know about like the raw foods, but the deli meat always throws people back and then you just see people going in on it.
The other thing, obviously, washing all their stuff, cooking meat
Yeah.
thoroughly, all of that.
And
needs to
hygiene,
happen.
thoroughly cooked meats, seafoods.
In fact, one of our infections we talked about today, toxoplasmosis, I think, is associated with raw meat
Yeah.
and kitty litter,
Mm-hmm.
but nonetheless, so there's that. So despite what we're doing, there are some, there's a fine line throughout pregnancy, and I learned this by working in the doctor's office um, as well as being a pregnant person. A lot of the stress of pregnancy is like, is this just a common discomfort of pregnancy, or is this a complication? And do I need to call the doctor about this, or is this something that is expected or just a possible discomfort, right? So there's a fine line, and it's kind of important to be able to differentiate some of that, including like I can almost count on my bet money I'll put down on somebody who talks about when I move a certain way, I get this sharp pain like going from my hip to my belly button. It's round ligament pain. I can put
Oh, that's the
money
worst.
down if they're like 22 weeks pregnant. I can put my money down on the fact that that is probably round ligament pain.
Yeah.
I'm not a betting woman, but if I was, that'd be a bet I
All
would
the
take.
time. They come in
Mhm.
all the time. I mean,
Yeah.
that uterus is growing, it's stretching.
Mhm.
That's because of that estrogen, right? Ups it, makes everything grow.
Thankfully, we do have that estrogen surging in the body because we need it to stretch. We need it to grow.
Then you get this comfortable all that pain right there. And like, what do you do?
Well, you rule out things, but if they're 22 weeks pregnant, they're saying every time I move, I got this pain. If they are making up the story in their head, well, maybe it hurts a little bit when I pee. Or maybe I'm having some discharge. We got to rule things out sometimes. Otherwise, we reassure them that it's normal round ligament pain. It will go away. But the best thing they can do is just support their lower abdomen. They've got these pregnancy belts and stuff that they can wear to just kind of help support those ligaments that have stretched and are protesting. That's all it
You
is.
could also have baby daddy help carry that belly up.
There we
That
go.
also helps. If they're supportive,
Put them to
put them to use,
use.
but also, take a little nap, resting, some Tylenol. Yeah. Those belly bands, they work. They do. I had twins, so let me tell you, they work. I had like the suspender ones. It was a look. I'm just saying.
It was a look indeed.
Yeah.
The other thing that I wanted to talk about, in terms of like normal versus abnormal, now I've just lost what I wanted to say.
Normal signs and abnormal in
Oh,
pregnancy.
I think what's important is establishing a relationship, a trusting relationship with with your patients, because if they are comfortable talking to you, they might be comfortable talking about, hey, I know this sounds crazy, but I've got this like strong urge to eat dirt, and I've been eating just a small amount of dirt every day because it's such a strong, overwhelming urge that I'm going to, like that I can't get away from. So what do you do then?
Or not just dirt, pretty much anything that's not edible.
So what is that?
That's pica.
Pica. What is the a very common association with pica?
Anemia.
Anemia.
Here we're back to iron one more time.
One more time.
Anemia.
So,
You gotta
if somebody reports that they're doing this, first of all, non-judgmentally figure out if there is a safer substitute um, to
To
dirt. I'm not really sure.
Pudding.
Cocoa,
Cocoa powder, maybe. Yeah.
some sort of maybe here. You know what I would do? Grind up a bunch of Oreo cookies. Could we consider that dirt?
Okay.
So
Okay.
if there's something to do, but bottom line is,
What about
check
as a
their
nurse?
H&H.
As a nurse, gotta assess them. Yeah, check
Yeah.
that H&H.
Check their H&H. It could be because they're anemic.
Yeah.
Maybe if we fix the anemia, it'll fix the pica.
Yeah.
But kudos to any nurse who can elicit that what might be considered shameful or embarrassing information
Absolutely.
during a patient visit. So
Yeah,
that's really
absolutely.
important.
What about other signs that are normal? Can we talk about that? Because I mean, like with pregnancy, your whole body changes.
Well, I think this is a great time to bring up presumptive signs
Okay.
versus probable signs versus
Okay.
positive signs.
All right.
Ah, presumptive signs the patient themselves can feel
Yeah.
or
So
report.
so like they're super tired. Their breasts are like
Tingly and sore.
feel like they're off, a lot of nausea too, and kind of like starts coming on with that morning sickness. You'll see as well.
Yeah. So these are some of the presumptive, presumptive is subjective. They can feel it or report it, but it's not really detectable by anybody else.
Yeah.
Whereas probable signs can be detected by somebody else, but it's not 100% that it is pregnancy. Positive signs of pregnancy, there can be no other thing that's causing it. An ultrasound showing a fetus in the abdomen is a positive sign of pregnancy, because if there's a baby being seen on the ultrasound, there's a baby.
There's a baby
right?
in your belly. Yeah.
What about, here's one. What about positive pregnancy test? Like you pee on the urine, pee on the stick and it.
Nope, not a positive sign. It's a
That's not a-
probable sign. Positive pregnancy test and Braxton Hicks contractions. Usually those two are people like, wait, what? Yeah, those are probable, not positive. You gotta see a baby or hear a baby or feel a baby. That's it. Everything's gotta end with baby to know that there's a baby.
And it has to be a
That's
practitioner
positive.
that does that.
Yeah.
All right, there's some other less obvious outward signs
Yeah.
that probably fall under like probable signs, like Chadwick's sign,
Chadwick's, yes.
Hager's sign. Those are what's
Cervical
Chadwick?
changes. Yeah. So Chadwick's is when the cervix has like that bluish purple color.
Mm-hmm. So all the down belows
Yeah.
are so engorged with blood because so much activity is happening down there
Yeah.
that
And Hegards is the softening of that
softening of the lower
uterine
yep,
segment.
yeah.
Of the
So
cervix.
those are things that a practitioner during an exam would pick up, but the Chadwicks, you might be able to see it upon visual inspection.
Sometimes I showed them a picture of what it looks like. It was like a bluish purple.
So we had pictures.
Cervix. So they had a picture of a blue purple cervix.
All right. Well, there you go. So that would be probable sign.
That's a probable
Very
sign.
good.
Other probable signs are hyperpigmentation. There's a lot like changes in your
Hyperpigmentation.
body. Yeah. You see, have you ever heard of pregnancy mask? Melasma, right on the cheeks.
I have.
Yeah, like bronzer for the cheeks.
Mhm.
Yeah, and then there's also like the Linea Nigra line up against the
Oh,
abdomen.
that's a good one.
What else? Breast changes as well.
Ooh, I remember a lot of my patients were horrified, and a lot of my friends who were pregnant at the now we're all becoming grandmothers, but um, they were horrified at like the changes, and they like woke up one morning and their nipples were like way darker than they were
Yeah,
before, and
darker
that for
and
some
thicker.
reason that horrified them. I don't
Yeah,
understand
I
it.
mean, your breasts are going to have major changes. So they're more vascular, they're larger, sore, darker. It all changes. Yeah.
Yeah, so that would all be those would actually be probable signs.
Those
Huh?
are probable
Yeah,
signs. Yeah.
hyperpigmentation.
Yeah.
Um, the those boobies, they're never quite the same afterwards. But anyways,
No.
there's that. What other kinds of things might we see? If I go back to what I started talking about, how is this a common discomfort or is this a danger sign, right?
Yeah.
Some common discomforts, I would spend some time if I were, say, a nursing student taking an exam.
Yeah.
I would spend some time just looking at common discomforts versus, differentiating common discomforts versus signs and symptoms of something, because this is both being covered, say, on like an exam
Yeah.
too,
Maybe in
right?
the future exam.
So spend some time looking at, because there's a chart right there in the book, common discomforts of by trimester, right? Third trimester, I gotta tell you, if my students know, my favorite organ is the uterus. You see a pink stuffy uterus right here. You see it right there.
Yeah.
My favorite hormone is oxytocin, clearly. My favorite trimester of pregnancy is the second trimester. Why? Because why you ask? You're not, but I'm telling you anyways. Because a lot of those discomforts kind of go away. You start to look pregnant, people know you're pregnant, and
You have
they're
a
treating you like
glow
the
to
queen that you
you.
are. You know what I
Yeah.
mean? But a lot of the initial discomforts of pregnancy, like the first trimester, um, are minimized. Maybe
Like, and you feel terrible, right? So it's
in
like
the
a
beginning you do, maybe you
yeah.
start feeling a little bit better. And then the third trimester comes along, now you start getting uncomfortable again, right? So that second trimester um, has fewer, in my opinion, discomfort
Yeah.
because
It's like varicose veins and hemorrhoids are like the worst of it because you have
right.
like this boost of energy. You have that pregnancy glow. Everyone's like taking care of you, getting
Yeah,
excited.
it's
And
good times. And then all of a sudden you can't see your feet.
yeah,
You can't breathe when you're laying down.
yeah, you're
All sorts of things.
baby breathing on your
Oh,
chest.
I can't fit into my shoes anymore
Yeah,
either.
yeah, that's
That's
that edema, dependent edema that you get, swollen feet. You have to go up a whole shoe size or two. I had
rough.
to go up a whole shoe size.
Did you? I never
Yeah.
changed my shoe size. That one I was spared from.
I
I
own a
was,
lot of shoes, so I was really
oh
sad.
no. What size are you? Oh, maybe I can.
I was a 6.5 and now I'm a 7.
Oh, forget it.
I didn't go back down.
Yeah. That's one of those changes that does not resolve after pregnancy for anyone
Yeah.
who's
What does resolve is the heartburn. I will say that. The heartburn was tough. I did have hairy kids, but they say if you
they
have a lot
say
of
the
heartburn,
hairier
you
the
might
kid, man.
have hairy
Absolutely
tibia. So,
nothing as
yeah, this is
scientifically
not
based.
scientific. This
But
is one of those.
you know
I
what?
understand.
We just have to try to make them feel better. But your child is going to be born with a beautiful head of hair when just to make them feel better because they've got this terrible heartburn.
Yeah, it's tough.
Um, let's see. What else can we talk about? Let's talk about let's talk about some danger signs. So we've talked a little bit, and I would become very familiar with the common discomforts, which are highlighted either in the PowerPoint, certainly in the book. Common discomforts by trimester. All right. Oh, here's another big one. It's in the first trimester and in the third trimester. Urinary frequency.
Yeah, you gotta pee a lot. I mean, pregnant women pretty much live in their bed or in the bathroom, I feel like. It's one or the other.
So while we do encourage moderate exercise, um, fatigue is a big one. Anyways, urinary frequency in the beginning, because in the first trimester, because the uterus is still in the pelvis and is like the place to be, right? There's a lot of action going on, and it's just kind of bullying, um, and like hogging the space. And the bladder shares that space. So the bladder is getting a whole lot more action too, and is running out of room because it's all about the uterus, right? Second trimester, favorite trimester, that uterus grows and becomes an abdominal organ, and all of a sudden the bladder just has a little bit more room. And so again, urinary frequency might temporarily um be minimized. All right. Then all of a sudden, third trimester
Yeah.
comes,
On
baby
the third
drops down a little
trimester.
bit, and all of a sudden, boom, bladder's being crowded again by, oh, that's so important. My favorite organ, the uterus.
Yeah.
Postpartum, we know, um, we've got to get rid of all that extra fluid so that urinary frequency doesn't go away. But somebody might call the doctor's office, the OB office, saying, "Hey, I'm getting up and having to pee like every hour," and within the absence of any other symptoms, we can blame that on a common discomfort of pregnancy. But sometimes there are symptoms that might indicate trouble, right? Let's talk about
Thick discharge.
Okay, let's talk about discharge.
What's normal? What's not normal? Bleeding, right?
Oh,
Bleeding, concerning.
bleeding, any,
Vaginal discharge that's white, normal. Bleeding.
right. But I mean, vaginal discharge that's white, if it is
Without
accompanied,
odor or pain.
accompanied by another symptom, odor, yeah, like whoof, like, I don't
It
want to,
makes you do the Libby move.
that might be a problem. Itching or discomfort associated with it. If it's clear discharge, then we got to rule out rupture of membranes, all sorts of things like that. But just some normal thick white discharge with no other symptoms, common discomfort.
Yeah.
Otherwise, could be. What about like headache, blurred vision?
Okay, we get it. You're talking about preeclampsia.
I am. I'm absolutely talking about.
Yeah, preeclampsia. Yeah, so headache, blurry vision, epigastric pain.
What's that?
Epigastric pain up here. So you just think like stomach, upper stomach, heartburn area, right? Not
Right.
contractions. Gotta ask them, what's the difference? Is it contraction pain or epigastric pain?
Epigastric pain. So it's actually referred pain from an angry liver, I believe.
Yeah.
That's causing that
And if you feel
epigastric
that, then we have a problem because chances are you might have some elevated liver enzymes that aren't, that's not a good thing if we're getting epigastric pain.
All right. Well, then if we're talking about elevated liver enzymes, I don't mean to go into this, but what happens if we do have elevated liver enzymes? What happens if we have some hemolysis, some anemia? What happens if when we're doing those tests, we check a CBC and we have low platelets? What's that?
You got HELLP syndrome. But that's like a complication. You got to treat that preeclampsia first, okay, before we're going to HELLP. Ideally, we want to prevent HELLP, DIC, or seizures, eclampsia, which is associated with seizures. I don't want to get to that point. So I'm going to try to treat that preeclampsia, manage it before I get to that point. And I'm going to hopefully manage that with some labetalol to lower the elevated blood pressure that's happening in preeclampsia.
Okay. What else?
You use
What else
hydroxy
might we use?
or mag sulfate.
Mag sulfate. Do we give that to lower blood pressure?
We give it for managing the preeclampsia, and it's going to do a bunch of stuff because that's going to help depress that central nervous system.
There we go. We give magnesium sulfate to prevent seizures. It might lower their blood pressure in the process, but we're giving it,
That's why I gave them the labetalol.
yeah. So
Solely.
we use it for CNS, central nervous system depressant
Yeah.
capabilities. All right. So, I mean, I'm just gonna give them a whole ton of it. No?
Depends. I mean, you want to have that on a controlled pump, but you have to monitor for toxicity. That would be good.
Toxicity?
Toxicity, mag toxicity. Yeah, I mean, how much mag are you trying to put in your system?
Well, I don't
You can
know. I
try
just
it,
figured
but I
the
don't think
more
the
the better,
patients
no?
want to know because they're gonna feel crummy and weak and flushed, and then you as a nurse have to monitor their blood pressures because they can tank their blood pressure, drop it completely. you don't want that, right? We don't want, just because they have hypertension, we don't want hypotension. Then you're also gonna look for respiratory depression. All
Okay.
right, so if their respiratory rate is like less than 10, like it's like 6, 8, not a good sign. You're also gonna look for decrease in urinary output because they have a lot of urine that they're usually making. But with MAG, if there's too much, it can actually decrease it. Now we're going less than 30. That's another red flag. And their reflexes is another thing you want to look for. So sometimes with patients that have preeclampsia with severe features, they have hyperreflexia where like their reflexes are like +4. And that's kind of also an indication they might be heading towards a seizure. Hyperreflexes and clonus. You know what clonus is?
Talk to me about clonus.
Clonus, okay.
I didn't
So
think too much about clonus.
yeah, but clonus, what we're doing is we're doing like dorsiflexion on the foot. We're pushing on that foot on both feet. And if we see ticking, okay, that is a positive indicator that they have
So push on the foot and
dorsiflexion and ticks.
and
Yeah.
it doesn't just go back down
Yeah.
normal. It like stutters.
Yeah,
down.
so that's clonus, which we don't want to see. Okay. I don't want to see clonus. And if I see that, that's pretty severe. I'm thinking this patient's gonna have a seizure. We're
Okay.
heading towards eclampsia.
So we give magnesium
To
sulfate.
reverse that, prevent that. Don't want that.
All right, but you're saying that we could give them too much.
We
So we
can.
have to balance how much we're giving them.
Yes.
So monitoring for all of those things to make sure that we're not going too far in the
Yeah.
other direction.
Like a good, nice control.
All right, well,
okay?
then I just have to ask you, what happens if you do give them too much?
Oh, you call a friend for help.
Call a
But
friend
you're gonna
And hopefully that
say,
friend.
all right, my shift is over. Bye. Yeah.
So turn the
No.
magnesium sulfate off.
Yeah,
number
I guess
one.
I could do that
Number
before I
two, you
leave.
can call a friend and ask her to bring some calcium gluconate
Yeah.
into the room.
Well, you should kind of
You should have
that
it
at the
on you,
bedside,
and
though.
I keep it
You
in
have a
my.
patient on MAG, you should have calcium gluconate on you because you're gonna IV push that and you are going to reverse that MAG toxicity.
So it's the antidote to
It's the
magnesium
antidote.
sulfate.
Yeah,
Very good. That's good to know.
it's the Narcan
You
for
might-
MAG
You might
sulfate.
want to know that one too, right?
Probably.
Yeah.
Yeah, definitely if you have a
Mhm.
patient on MAG.
So I mean, we don't, if they're being if their respiratory is like severely depressed, that's not good. Speaking of
Yeah.
respiratory, what about asthma during pregnancy? Does it, I told my class today that sometimes it's actually asthma is sometimes better during pregnancy
Yeah.
because that smooth muscle relaxation, that estrogen flowing through the system. But some people, we obviously want to make sure their oxygen levels are good. And the best way to do that is to just be mindful of, which I'm sure patients are, but they have to keep in mind. It's all the more, you're not the only one needing oxygen now. There's a growing baby that needs it.
Yeah.
So they need to just avoid those, acknowledge, figure out what their triggers are and avoid them.
Absolutely.
possible.
Yeah. I
So
mean,
asthma is a real. it's
people are going to
real.
come in with like different past medical histories, comorbidities. So it's a question of like managing,
Yeah.
recognizing triggered. What about patient with HIV? I always like to have these patients with HIV, hepatitis, things like that.
You know, we've come a long way, just even in my time, although I know I've been in it a long time, with the management of HIV. And I was telling my class today about what a wonderful opportunity to cooperate with our infectious disease colleagues while monitoring viral load and that sort of thing. What our goal is to continue in the pregnancy as long as possible for the fetal health. And it's okay, there are some patients who can deliver vaginally. Ideally, we do deliver vaginally. There's less chance of maternal fetal or newborn exposure to maternal blood in a vaginal delivery, to be honest with you. So, but it's all about the viral load. We have to keep the viral load low. We have to minimize exposure to maternal blood. And whether that's no internal monitoring, no episiotomy, we're going to clean that baby up real good after birth before giving them injections. We're going to put them on 6-week oral antiviral.
Yep.
A retroviral, if you will.
Antiretroviral,
Course. And doing all of that has actually nearly eliminated maternal newborn transmission
Yeah,
of
the perinatal
HIV.
transmission has gone down, yeah.
Yeah, that's awesome.
So we've come a long
We
way.
have come
And
a
it's crazy to
long
think it
way.
was just a few years ago, like
Yeah.
things were different, so.
Yeah, it wasn't, it was within my time here as a nurse. And I ain't
No.
that old,
Yeah. She's
105.
like, okay.
Let's see, what else do we have? We've got a lot of testing.
A lot of testing that can be done prenatally.
Some of this is okay. We have the basic testing that we might offer all patients.
Yeah.
Like the maternal serum alpha fetoprotein, MSAFP test.
Yeah,
All
yeah.
right, it's just a blood test in mom. This is how I remember it. If that blood test, the AFP or alpha fetoprotein, is decreased, then that could be indicative of a Down syndrome.
Yeah, trisomy 21.
If it's increased above normal range, that actually can be indicative of open neural tube defect, by the way. How do I remember that so strongly? It was a student who
Tell me.
actually said, I'm gonna tell you,
Tell
I'm
me.
gonna tell you. The down low. I'm giving you the down low, and that's how I remembered it. If it's down, meaning Down syndrome, it's gonna be low. The down low.
Okay, I like that trick.
Yeah,
That's nice.
that's the only reason I firmly remember that if the AFP test range result is lower than the expected, that it's a higher risk for Down.
Trisomy 21,
syndrome.
nice. And if it's up, what can we say? Maybe like your back holds you up, neural tube defects.
No, it's just the other one for me.
Or-
But yeah, no, I like that. I like that.
Okay, why not? Or you're just having twins. But that's why you have to do it between like 16 and 18 weeks. You
Right.
got to know how far along you are. Your gestation really does make a
It
difference.
absolutely does
I
at
don't
that
know when
point.
it
There are
is.
other prenatal tests that we do. That might also help with like we build upon
Diagnosing.
we build upon the risk factors. There's screening tests, and then there are some diagnostic tests. Those diagnostic tests, I know Professor Lopes went over with you, include things like chorionic villi sampling.
Yeah.
Wow. We can learn so much from it.
Okay.
It's not a screening test, it's a diagnostic test. And quite frankly, it's not without its risks.
Yeah.
What
yeah.
risks are we talking about?
If they have that done, and usually patients are going to be at least like towards the end of like their first trimester,
Mhm.
but we always want to make sure that our patients are aware to check for any like spotting, vaginal bleeding, cramping, because there's always risks of like a miscarriage, and we want to obviously avoid that. So we always want to make sure we educate them on that.
Yeah. The other test that I'm thinking of that we do earlier in the pregnancy, we may also do it later in the pregnancy for different reasons, is amniocentesis. That's a big old ultrasound guided needle
right in the belly.
in the belly. Did you have that done?
I did not
No,
have that
good,
done.
thank
I didn't need it done, nor
Mhm.
did I want that done.
Right.
That has its own complications.
It absolutely is. I mean, but it will give you it's a diagnostic test.
Yeah.
CVS, as it's called, chorionic villi sampling, or amniocentesis is literally testing the genetic material of the fetus.
Yeah.
Therefore, diagnostic. It's
Yeah.
not a risk factor, it's not a screening. It's gonna tell you for sure any chromosomal abnormalities.
Just be careful
Mhm.
with the amniotic fluid leakage though after that amniocentesis.
Oh, so that's not
something I
without
was
its
trying-
risks.
That's not, well, nothing's without its risk,
Right.
but definitely be mindful of the amniotic fluid leakage after.
So the thing of it is they need to be aware of what to look for because they're not staying overnight with us or anything like that. They have to have a very good reason to have these tests done because we have to look at benefits versus risks. If they are going to make decisions based on the results, then those risks, the benefits outweigh the risks for them. As long as they are well educated about those risks and know when to contact their provider.
Yeah, that's great. And that actually makes me think about RhoGAM. Because a lot of times throughout pregnancy, if women are having certain procedures, some women, based on their blood type, are going to need RhoGAM.
Well, that's a good point. What about like if they had a miscarriage?
Yeah, they're gonna need RhoGAM.
If they're RH negative, they're gonna
If they're
need
RH negative, so RhoGAM is given to any mother with a blood type that they're RH negative. So A negative, O negative, AB negative, B negative. And if you're positive, you don't need this. And you're gonna get it in pregnancy regardless at 28 weeks, usually,
Mhm.
everyone. But also if you're having certain procedures done, and then if you have a miscarriage as well.
All right, so
So you don't have to
anytime,
wait.
anytime, the pregnant person could be exposed to fetal blood.
Yeah.
So anytime, they will get that RhoGAM, I guess.
Yeah, so it's certain like testing and like we talked, diagnostic testings are out. So if they have an amniocentesis at some point in their pregnancy, they're RH negative, they're gonna get that RhoGAM. And it's
So-
not 28 weeks.
So you're saying though, if they had a miscarriage, maybe they just found out they were pregnant, they haven't even sought care yet. And they, maybe there's like 6 weeks along or whatever, they have a miscarriage. They should, if they're RH negative, they should go get RhoGAM.
Yes, they should.
Just-
Doesn't matter.
All right, that's good
Alright,
to know. I
anything
mean,
like that.
you guys know what your blood type is? Probably important to know.
Yeah. And you should know your partner's blood type too. Why not?
Why not?
You just ask. I mean, RhoGAM is indicated because pretty much any woman that's RH negative, there's always that chance that they can have an RH positive child, and that could lead to fetal anemia, even hemolytic diseases with further pregnancies if they have other children that have RH positive blood. So it's definitely something they got to know. So
Wow.
I told my students, like, when they go on a date, depending on who they're, married to or dating right now, ask them what's their blood type.
Hey, what's your blood type?
Yeah, because if they're RH
It
negative,
should be on the Bumble profile.
but
Bumble?
Bumble.
That should be on Bumble profile or
Yeah, I don't think
Match.com or
Bumble,
Tinder.
Hinge, that's the other
Okay, I
one.
don't
That's
know.
that's from, I guess, more serious commitment. So I've been.
Oh, then. Good to know.
I didn't have to do the online dating.
I didn't
scene,
either.
so,
Although maybe it would have worked out better for me. Anyways, let's talk for a minute about some other complications while we're talking about
Yes,
complications.
other complications. There's a lot.
Things that we're checking for, we're screening for. What about diabetes?
Diabetes, another complication. Yeah, so usually there's the glucose tolerance test.
The glucose,
Around 24 to 28 weeks, we do that.
yeah, that's a glucose challenge test.
The Jolly Rancher drink. That's how I think of it.
I described it today as flat orange soda, that the machine is broken and all you're getting is the syrup.
Oh, yeah. Yeah, it's syrup. Yeah, it's a thick
Called
glucose
Glucola. If that tells you anything.
Yeah, and so for the 1 hour, it's what, 50 grams?
50 grams.
You drink that, and then they check your blood sugar an hour after consuming that.
Okay.
So that's the standard. Everyone pretty much gets that while they're pregnant. However, if you fail that, then you need a 3-hour glucose tolerance test, which is you drink 100 grams.
Yeah,
And
you
they
come
check
in
your
fasting
sugar.
for that one. They do the
Yes.
fasting glucose, give you that terrible drink, and
And then
keep
you
you around.
check it, yeah, at 1 hour, 2 hour, and 3 hour. And if you fail 2 of those,
In a minute.
then you have gestational diabetes. So yeah, it's not a thing. Then you need to do
That's
finger
tough.
pricks, might need insulin, metformin, sometimes
I-
diet control.
I gotta tell you, the blood sugar control was much stricter during pregnancy than outside of pregnancy. I would spend, I know for a fact, and
Yeah.
I honestly, because I'm in the OB business, I don't know what blood sugar ranges are normal outside of pregnancy. I will tell you that during pregnancy, we want a fasting glucose less than 95. I
Yes.
think outside of pregnancy,
Yeah.
it's above 100, or under 100, but I really don't even know.
Yeah,
Under 95, definitely.
under 95 and pregnant.
Mhm.
Then what about postprandial?
Postprandial, depending on the provider, depending on the protocol at like the hospital, if they're in the hospital, they may check 1 hour postprandial.
Mm-hmm.
And that I would say is like less than 140-ish.
140, yeah.
And
pretty
a
standard.
2 hour postprandial is under 120, I believe.
Yeah.
Yeah.
Yeah. It just does depend on what the providers order, but
Yeah. So I would definitely be very firm about those ranges.
Yeah, those are good numbers to know.
Those are good numbers to know.
Yeah.
Some other,
Can we also talk about numbers just in general?
we can absolutely talk
Let's
about.
talk about, Nigel's rule, calculating
Mm,
pregnancy, like when your due date is.
This is a party trick.
Yeah, for those of you that like, might be going on a first date, things to, impress your date with, Nigel's rule.
That'll scare the heck, that will run
Find
far
out
and fast.
when they might have been conceived. If their birthday was ideally 40 weeks on the dot.
There we go.
And then also find out their blood type. That wouldn't be
those
awkward at
things,
all.
Yeah, that's why, thank goodness she's not in
Yeah.
the dating.
I would say I probably wouldn't ask for a second date, but teach their own. I'm just offering. up
Nigel or Nagel, Nigels,
Nagel.
Nagels,
Oh.
however you pronounce it, Naegle, Nigel.
You will have a question on how to spell that.
No, just know the spelling. But what is it? It is subtract 3 months, add add 7 days, and 1 year.
From the first day of the last menstrual cycle.
Yeah, sorry, I didn't
You
say that
forgot
part.
that like important
important,
part. You
that's
need to know
okay.
the starting point.
So
So don't take math lessons from Dr. Lewis.
Actually, you should
Let's start
take
off
math
there.
lessons from him.
Yeah, okay. Well, we start off with the first day of the last menstrual period.
The first day of the period. So
Yeah.
they're not even pregnant yet, is what you're saying.
Yes, they're not pregnant yet.
All right, so their
First day.
period started on July 4th.
Okay,
Happy 4th of July to you.
great.
Got
That's
your
when their period starts. Yeah, red. Okay, it's a great color. Why not? Love bleeding. Yay, it'll be except when you're pregnant, no bleeding.
No.
Okay. And then you are going to add a year if it's less or if it's after April. So this is July, so we're gonna add the following year. So say 4th of July, 2025. So now we're looking at
So 4th of July, 2025, subtract 3 months, that puts you into April. So subtracting 3 months is April 4th, 2025.
okay.
Then we're gonna add 7 days,
Okay.
April
4 plus
11th,
7.
2025.
Good. Right. You should need a calculator. Isn't that impressive?
and then add 1 year. So April 11th, 2026. If your last menstrual period was July 4th of this year and you had a little fun mid-July, your due date would be April 11th next year. Just letting you know. That's
Spring baby.
spring baby.
All right.
So, okay, there's 2 things you need to consider. And maybe not for this test, but maybe for a final or maybe for like the nursing board test. If in subtracting the 3 months, how about this? If in subtracting the 3 months, you go into the year before, so if your last menstrual period was February 4th, you subtract the 3 months, you're now in November, if I'm not mistaken. January, December, November of the year before. So you have to go, if you're subtracting the 3 months, you go back to the year and then you can add the year, but don't add 2 years. You got to remember that when you're going back the 3 months, you're going back into the year before.
See, that's why I did the year first after the first menstrual period.
there,
So if
whatever.
you just
Just
do
think
it
about
that
that.
way and add the year if it's after April from the last menstrual period, then do minus 3 months plus 7 days.
All right. The other
Just
thing I
complicate
suggest you remember is how many days are in each month. All right. If my last menstrual period was July, my last menstrual period was years ago. But if my last menstrual period was July 28th instead of the 4th, and I went back 3 months, April 28th, and then I added 7 days, that's April 34th. It's 35th, April 35th.
Makes sense.
Or is it May something? How many days are in April? See, these are the things you need to know.
Yeah. So study a calendar. Study one.
Do you guys know the knuckle trick?
I don't. I know it's something like where the knuckles. I don't know if it's knuckles or in between. Is it 31 days or 30?
The knuckles are 31.
31.
The in between the knuckle is not 31. 28 or 30, right? 29 or whatever. So January is a knuckle. 31. February, not 31. March, April, May, June, July is 31. Guess what? Up against another hand, August. August is also 31 because the hands told us that. Boom, 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 across the way. So,
That's a good party trick. You should also do that if you go on a first date. I'm giving you guys a lot of dating advice.
yeah, look, if you're gonna go with Professor Lopes, yeah, you're gonna have a lot of first dates. That's all I'm gonna say.
Yeah.
I don't know, second
Hey, they keep
dates.
them interesting.
Anyway, so there's Nigel's rule. The
Yeah.
other number thing, T-Pal. T-Pal. First of all, what's gravida? What's
Good
gravida?
T-Pal. Don't
Good
forget that
T-Pal,
G.
GT-Pal. What is gravida
Number of pregnancies.
throughout their entire life?
Entire life.
All right.
Yeah, I mean, compared to what? What do you mean their entire life?
I don't
Okay. All right, yeah, so number of pregnancies.
know. All right, T-Pal.
T-Pal.
T,
Term,
P,
preterm,
A,
abortions, less than 20 weeks,
L,
living children.
K. This is what I need to say to you all. When you see G in a number, that's gravida. And then if you see P after it with 4 numbers with dashes in between, that P is para,
Yes,
not preterm.
correct.
All right.
Yep.
So you see a P with 4 numbers afterwards, it's para expanded to T-Pal.
Yeah. A lot of times in practice and in clinical, you might just see like G4P2. So she just has 2 living children and this is her 4th pregnancy. But when you see the extension of the number,
The 4 numbers with dashes oftentimes in between. Don't get confused that because unfortunately there's 2 P's involved.
yeah.
You see a P with 4 numbers, it's para expanded to T-Pal.
Yeah. So it'll
Right.
say P, but then it's like your term, your preterm, your abortion, and your living children.
So don't worry about that P there. If you see those 4 numbers,
Yeah.
it's T-Pal.
Yeah, that P is kind of associated with the L, the living children.
More or less.
Yeah.
Here's something. What's the difference between term and preterm?
Less than 37 weeks is preterm, greater than 37.
Between 20 and 37 weeks is preterm.
Yes, yes.
And less than 20 weeks is A, or abortion, whether spontaneous or therapeutic induced, if you will. Anything that a pregnancy ends before 20 weeks, it's A.
Yes, and if it's a stillbirth, it's gonna go under preterm or term.
Depending on the
on
gestation.
gestation. So how many weeks that stillbirth infant was, and then we have,
But it wouldn't come under L.
yes, it wouldn't come under L. They know that. If they paid attention, they know that.
Good to know.
Yeah. What about twins?
Whoa, I don't want to talk about it.
Hey, I had twins.
I know, but you can go in. First of all, twin pregnancy is 1 gravida.
Exactly.
But you can go I promise never to give you a test question about twins. You know why? Because you can find reputable sources that will say the exact opposite thing. Both. Some people say it's 2 deliveries. Some people say it's 1 delivery with 2 living children. I'm here to tell you.
Yeah, but how does that influence your L, your living children?
It doesn't, but it can affect your T and P.
How? If I have one at 37, at 20 weeks and one at 37 weeks?
No, Professor Lopes. It's gonna be if you have not had any other pregnancies and your first pregnancy was a twin pregnancy.
Yes.
Gravida 1.
Pair 2.
And yeah, para 2.
Mm-hmm.
But what if you're trying to expand to T-Pal? Is it T2
Yeah.
or is it T1? Because it's 1 delivery of 2 living children. I'm telling you, it gets confusing. Yeah, it does. And I, as half of you,
You're making it so much
Professor,
more complicated.
it is complicated because depending on who you ask, will depend on what the answer is.
Okay, so trick question. We should trick them.
You can go ahead and trick your student. I'm not going to trick mine. The only problem is NCLEX might trick you on that.
Okay. NCLEX would.
There are reputable sources that say it's a separate delivery for each child. So the T or the P, depending on gestation, will be either 2 for twins, 3 for triplets, blah, blah, blah. Other reputable sources will say it's 1 delivery, but the living children part, the L would be changed. I'm telling you, it's different. I'm glad we talked about that.
Yeah,
And
I'm
we haven't cleared
so
it up at all
glad.
for you, but I will tell you that this particular test that's coming up doesn't have anything to do with twins. When it comes to
It might
TPAP.
change in your sleep, you don't know.
Well, if your test has it, your professor's mean.
That's not nice. It's not very nice.
You know, we do a lot of counting, right? So just know TPAP, in and out, know it.
A lot
all
of
right?
numbers, a lot of
A
numbers.
lot of numbers. The other number that we ask a lot of our patients is like, particularly in the 3rd trimester, because they're not with us, 24 hours a day, 7 days a week. So
That'd be
we ask them to do things like kick counts.
Kick counts, yeah.
Yeah. So we want our babies moving.
We do.
What's abnormal? What's an abnormal kick count?
Less than 10 kicks in a 2-hour span
So
would be
less,
abnormal.
okay.
Would be abnormal? I mean, why'd you ask me what's abnormal? Ask me what's normal. Normal. 10, some form of 10 movements within like a 2-hour time is normal.
Okay. So if it's less than that, that's abnormal. What happens if it's like,
100,
well,
20.
that might get a little weird, but what about, we'll say it's 26.
Okay, that's
kick
normal. That's more
in
than
2
10.
hours.
10 or more. 10 or more. in
So you
2
want
hours.
10 or more.
Yes.
That's
Fetal
important stuff.
movement.
All right.
Yeah, it is
So if it's
important.
less than 10,
Yeah.
then that's a problem.
Yes.
Or could be a problem.
Yeah. If I
It's
mean,
reportable.
so once you're feeling movement, which should only be happening around 20 weeks, just
Mhm.
saying.
Mhm.
Some people, if it's like their grand mole tips, is in their first pregnancy, sometimes they feel fetal movement like even at 16, 18 weeks.
Mhm.
Some people first pregnancy can be 22 weeks, but like you gotta leave at like the end of that 2nd trimester, definitely 3rd trimester, we're doing kick counts.
Yeah.
They should be feeling that fetal movement. That's very important. Otherwise, we've got to call them in. If they're having less than 10 in that 2-hour span or not feeling that baby move, they've got to come in.
They got to come in
They
and
got
get
to come
checked.
in and checked out.
What happens if the patient tells you, I've had patients now, because I worked in the OB office. I had a patient who's literally like 8 weeks pregnant. Oh, I feel the baby kicking.
Yeah.
Oh,
Yeah.
really?
Maybe it's a
Well,
gas bubble.
what exactly did it feel like to you? That's what I would say. I wouldn't want to be like, hey, you're crazy. But of course, that's what I'm thinking. Because they can't possibly feel a baby move that
Yeah,
early
that's
in
right.
gestation.
That's what
First of
I'm
all,
saying.
because things are way too
Every 20
small.
weeks.
Quickening is that initial flutter feeling that they can feel, but nobody else can.
Yeah.
All well and good. But it doesn't happen till like 16, 18 weeks
Yeah.
at a minimum. But 6 weeks, 8 weeks, they're feeling something different, or their mind is just so excited to be pregnant that they're thinking this little gas bubble is fetal movement.
Yeah.
But we got to establish that trusting relationship again. So therapeutic communication involves, ooh, tell me more. What are you feeling? Just to make sure that it's not a sign of complication, and to clarify and educate what's normal and what's abnormal.
Yeah.
In a way that's not like you are absolutely crazy.
Yeah.
I would avoid saying those words.
Yeah, that'd be nice. Once had a patient who was in her first trimester tell me that she can hear her baby's heartbeat with a stethoscope on her abdomen. She was like maybe 12 weeks, if
12
maybe
weeks.
beginning of her 2nd trimester. Yeah,
Yeah,
that she
that's
can
somebody
hear with a
hearing
stethoscope.
their own
Your
heartbeat.
uterus isn't even in the abdomen area.
Yeah, say
So-
you can't even check the abdomen before, because you can check for cardiac activity on a transvaginal ultrasound, in the first trimester, but you can't on the abdomen because the uterus isn't even in the
Yeah.
abdomen yet.
So, and that's what you have to also do fundal height checks when you're pregnant. So a lot of times in the prenatal visits, the provider's gonna measure your fundal height. So like in the first trimester, you don't have that. It's usually closer to 20 weeks is when they start fundal height checks. Obviously it's provider preference, but usually
Definitely
based on
after
the-
anytime after 16 weeks is
Yeah.
reasonable. What about fundal heights?
Fundal heights, measuring it in centimeters usually, and your fundal height is usually or should be equivalent to about how many weeks gestation you are. So if you're like 24 weeks is what you're measuring, or your fundal height is 24 centimeters, then we guess that you're about 24 weeks pregnant.
Okay, so I'm getting measured in centimeters,
Yes,
from my pelvic bone to my fundus.
yes.
In centimeters, it should be roughly equivalent to how many weeks gestation you are.
Correct.
This is cool. This is a very low tech approach because we don't do ultrasounds every visit.
No,
So if I come to you as the provider at 24 weeks and I'm measuring 28 centimeters,
you're how many weeks?
24 weeks,
Okay.
that's a cause for concern. Maybe not, maybe there's nothing wrong per se, but that's a low-tech screening approach to say, we need to investigate further,
Yeah.
right? Because or if I'm 24 weeks gestation by my dates, and I'm only measuring 20 centimeters or 22 centimeters. Let's go in, let's take a look to make sure her amniotic fluid levels are where they need to be, that the baby is growing the way they need to be growing, that sort of thing. Because it could be like too little or too much amniotic fluid.
Yeah.
What is too much
Large baby.
amniotic fluid called?
Polyhydramnios.
What is too little amniotic fluid?
Oligohydramnios. I'd
No.
pass this test if it was.
There we go. Polyhydramnios
Yeah.
is too much. You're
Too
saying.
much. Too much.
Excessive.
Oligo, not enough.
Oligo.
Think of almost like zero, none, little bit.
That
There's
is
still
good.
fluid. I
All
just
right.
think that's a way to remember.
That is good.
Oligo.
That is good.
Just a little bit. So poly, big baby, or prolapse. All right. A lot of issues. That's malpresentation where the baby can be flipping around.
We're talking about busting that bag of waters and having a big old gush. Anything
man.
could come down and
Yeah,
it
that's
could cause major troubles.
I once had like new sneakers. I was really happy about them. New grad, got myself these new sneakers. Someone's water broke. She had poly hydramnios and the water got everywhere. And then I learned I'm not gonna get nice shoes as an OB nurse because I had baby shoes everywhere.
Yeah, it's baby juice, mommy juice.
It's someone's fault. It's amniotic fluid. It's the baby's cushion. It protects the baby.
It's human juice.
But
we don't want it on the shoes we're taking home. I'll tell you that.
Yeah, I mean, leave your shoes at work.
Leave your shoes at work.
Definitely.
We'll clean them off, whatever.
Yeah.
I have one other thing to talk about. There's a couple of things to talk about, but if we're still talking about numbers. All right. Oh. But how about this? We have a woman has an increased BMI. All right. So, okay. She's downright obese. All right. Versus a woman who's normal weight or a woman who is underweight. Do we tell them all the blanket, I want you to gain 25 to 35 pounds during pregnancy? So we have an obese woman prior to becoming pregnant comes to us.
Yeah.
And she wants to know what a normal weight gain is for pregnancy.
Obese? 10 to 11 pounds to 20 pounds. Usually, yeah, on less than 20. Yeah, I like the 10 to 20 range, someone who's obese, and then someone who is underweight is going to be a lot
gaining more. And so what we're saying is, what we're hoping for with both under and overweight patients is that they make different lifestyle choices that if they weren't pregnant, they'd either gain weight or even though they're not pregnant, or if they weren't pregnant, they might actually lose weight. So they're making better food choices. Maybe they're moving more, activity wise, they're exercising a little bit more. So that if they weren't pregnant, they would actually be losing weight.
No.
We don't recommend them losing weight during pregnancy, but just
absolutely
making those better choices so that the weight that they're gaining is simply fetal and amniotic fluid and the uterus growth, that sort of thing.
Yeah, and that's why preconception care is so important, because someone who's obese can start working on healthier lifestyle modifications, losing some weight, and someone who is underweight has that low BMI can start putting on some weight. So that's the opposite, where we want them gaining like 25 to 28 pounds to 40 pounds if they're underweight. So healthy is 25 to 35, the norm,
Norm is 25 to 35. Obese or BMI, usually it's over 30.
30.
Would be like 11 to 20 pounds
Yeah.
weight gain. And you're saying underweight's like 28 to
Yeah,
40?
28 to 40 underweight.
Mm.
Yeah.
So there's that. I know that there's just so much to talk about, and I could sit here and talk about it forever. But I want to spend a couple of moments differentiating between some placenta issues.
Yeah, we gotta talk about that.
Yeah. Placenta previa
Yes.
versus placenta abruption.
Yeah. So both different. So your previa, a lot of times you kind of that can be identified while they're pregnant,
Mhm.
kind of where their placenta lies. Sometimes it's marginal, sometimes it's partial or completely over the cervix. If you have that partial or complete, they're gonna be, they can't really go vaginal. They have a vaginal delivery. And I always think like pretty much nothing vagina is what I say when they have a previa. So no vaginal exams, no vaginal delivery, because you can't deliver that placenta first before a baby.
Yeah.
That makes sense in your head. Also, they're gonna have some bleeding a lot of times. Sometimes that's how we identify it
Mhm.
too. They come in with some bleeding.
Are they in pain?
Not usually. Usually the pain's gonna be with the abruption.
Okay.
That's my red flag. Bleeding with pain, I'm gonna think abruption.
All right. Painless, bright red bleeding could very
Previa.
well be a previa. So what's the first thing I'm going to do? I'm going to do a vaginal exam and check.
No. You shouldn't. If you see bleeding, don't check them. Do an ultrasound.
No,
I just
nothing
said
in the.
that. I just
I
said
know.
nothing
I
in the
just wanted to
vagina.
double
You were testing me.
verify
Very
that. I was
good.
testing
Yeah.
you.
Okay.
Testing you.
Yeah.
Nothing in the
Thanks for not
vagina.
listening.
You do not want to poke your finger through a placenta.
Yeah, I don't.
You don't want to do it.
A
You don't want
placenta
to. No
for a
vaginal
baby's
exam.
butt, don't do it. That's my recommendation.
The thing of it is, you need to check an ultrasound. If there's a prenatal record on board, check, because there'll be something in there that will, before you can go anywhere near the vagina, you have to check to see where that placenta is. And if there's no record in the chart of where the placenta was on the last ultrasound, get an ultrasound.
Yeah.
Do not do a vaginal exam.
Yeah. And then with abruption, that's where you're gonna have pain. Their placenta is like separating. There's a lot of bleeding. They're in pain. Their uterus is like rigid and tender. It hurts. You're going to the OR.
Yeah, most likely in those cases.
Yeah.
All right, so that pain and tender, rigid uterus is probably the differentiation with those placenta issues.
Yeah.
Mhm.
Pain tells you a lot. Both bleeding, but pain.
There's some other things that there's one thing we didn't talk about, and maybe it's the only thing we haven't talked about. If we're going back to numbers, because that seems to be how
Numbers. We
think
love
this.
numbers.
We love the numbers. And screening tests and fetal surveillance, that sort of thing. We talked about, we didn't talk much about, and we don't necessarily have to for this exam per se, but some of the things we might do to make sure the baby is doing okay in that third trimester is for people with like high blood pressure, old people, fat people, diabetic people. So if you are old, fat, hypertensive, and diabetic,
and young, okay, she forgot young people too, right? If you're young, old, and fat, you have all these complications, right?
All right, so we know the vulnerable population. I'll say that. But nonetheless, whatever risk factor you have, we're doing some extra surveillance because we've learned that it's not just a risk to you, it's a risk to your growing fetus. And so there's things we can do, and we'll pick up on subtle signs of distress, and the baby's not getting what they need. One of those tests is a very specific targeted ultrasound called a biophysical profile.
Yeah. BPP.
BPP. It's got some elements. We're looking at amniotic fluid level, polyhydramnios.
Yeah.
We're looking at fetal breathing practice. We're looking at fetal tone, fetal
movement.
Fetal movement. What about fetal gender?
Fetal gender. What? No.
Are we looking at fetal weight?
No. NST. We do that. So like the baby's heart rate. Okay.
All right, so I'm just,
Movement,
that's what, it's a very targeted
Home.
ultrasound. It's not about those other things.
breathing, amniotic fluid,
All right. And the non-stress test, so we're
and the
looking at fetal
non-stress
heart
test.
rate.
Yeah,
tracing.
sometimes that's not always done, so if it's like 8 to 10, that's good, but anything less than 6 is concerning. That's what you need to know. Less than 6, red flag. Greater than 6, you're okay. Because sometimes they do the NST or don't, so like, 8, fine, if they didn't do the NST. Goal is 10, it's out of 10.
So
but
10
nothing
out
under
of
6.
10 is perfect score.
Yeah,
Nothing to be worried about
10 out of
at this
10, yeah.
time. Bring them back in 3 days from now,
Yeah.
whatever. 6 out of 10 or less than 6?
yeah,
Now,
less than 6, we're concerning. Think about
Okay.
it, like when you go on, right, well, let's go back to dating. You go on a
Oh,
date,
here we go with
right?
dating.
Would you want to go on a date with someone who's a 10? Maybe an 8. Is that 6 and under? I don't know. Yeah.
Oh, or do you want to go on a date with somebody who's talking
I
about
hope you're all like
dating?
married and in serious relationships at this point.
Well, if you aren't, please don't take advice.
Don't take my advice.
Sure. I really feel like we've talked a lot and I feel like we've covered everything. Have we?
I think so. I don't know what's left to talk about. I'm all talked out. I mean, pregnancy's hard. It's complicated. Take care of the pregnant people in your lives.
Well, isn't that just?
And wait till you're done with nursing school to get pregnant yourself.
Well, no, I mean,
That's
that's
my
good.
advice. No, that's a life choice, but that's
It's a
my
life
advice.
choice. We'll support you either way.
Yeah.
However, these are really important things. Just remember, two things. One, when we're taking care of a pregnant patient, we are actually taking care of at least two patients, right? The patient we can see, touch, and talk to, the patient we can't see, touch, or talk to, right? So we need to be mindful of everything we're doing, that we're mindful of both patients that we're taking care of. And of course, she gives you her little nuggets and words of wisdom. My word of wisdom is that this might be in just one other day at work for you. This is a very important moment, and very important. They might be extra nervous and anxious about certain things, so have patience with them and remember that we are guests in a family's memory at any point during the pregnancy, and they might remember your kindness and how you treated them and made them less anxious, or they might remember that you were downright mean to them, and or
That's true.
talking about it literally 40 years later. All right, still remember you as the mean nurse who dismiss their concerns and their anxiety. I'm not.
She was my
No, I
nurse.
saw that point in my direction. Amen.
That's it. That's it. Take care of your patients. Be mindful of their situations. Take care of them emotionally and mentally as well.
And anything we talked about here today, if it didn't make sense to you or you don't even remember hearing about it in one of our class times together, go back to the PowerPoints. If that doesn't do it for you, please go to the book. All right. We're trying to be as consistent with the textbook as we can. We tell stories along the way so you can kind of remember. But if that's not enough for you and you don't feel like you have a firm grasp on any of these concepts, read about it in the book. All right. You can never go wrong with that simply because you got to NCLEX to pass at the end too. And we don't want to narrow your focus so much just to pass this test.
All
So
right.
do that.
Bye,
Okay.
guys. Take your vitamins.
There it is.